stop sharing my screen. Oh.
And so I'm glad there'll be some more time for discussion. I didn't realize it would be so long, which is good. I actually did not include cases at the end because I thought we might not have enough time for discussion, but this will be better. So
maybe the attendants will submit their cases to be discussed online.
Okay.
Monsieur Shady, Mr. Shady, Mr. Shady.
Yes. So it's my pleasure to introduce first the moderator of the session, Professor Ahmed Borza. Can you hear me?
Yes. Can you hear me?
Michael.
Yes, I can hear as well.
Okay, so Professor Ahmed Borza, the moderator of the session.
Thank you, Mr.
The
Shady.
chair is joining us, and it's a pleasure to see all of you among us here for the successful of this initiative. So maybe we have the people on the way to join us. Maybe we can wait for some minutes before starting.
Yes, no problem. Just let me
No
know.
problem.
Share screen, it's wonderful.
Mr. Shady?
We can start?
We can start now or not?
Yes, okay. So, hello, everybody. It's a pleasure to always have you all join us for the second webinar on MS and related disorder with the focus on treatment strategies. So this initiative is the cooperative effort between the neurology department at Mohammed V Military Hospital of Instructions in Rabat, Morocco, and the Moroccan Society of Clinical Neurophysiology, which hosts a series of online expert briefing on the various developments and potential outcomes in the diagnosis and management of multiple sclerosis and related disorder. So the program of the second online session will include a presentation by our keynote speaker, Professor Michael Kornberg from Johns Hopkins Medical Institute MS Center, US. It will consist of 45 to 60 minute presentation followed by 30 minutes of question and answer. As the session will be moderated by Professor Ahmed Borza, who is the chair of neurology department at the University Hospital of Military Mohammed V, Rabat, Morocco. I now yield the floor to the moderator for the introduction of our keynote speaker. Professor Ahmed Borza, the floor is yours. Thanks.
Thanks, Mr. Shady. I'm very happy to be with you in this session of webinar. We are consecrated to the MS and related disorders, and especially for therapeutic of multiple sclerosis. And everybody know that they have many developments in therapeutic of multiple sclerosis, and the neurologist must choose what drug must be used and must be efficacious in his patient. So several problems must be considered when we are going to treat patient, like clinical form of multiple sclerosis, activity of disease, and the safety and tolerance of therapeutic and the course of disease. It's very important for the neurologists to know when and how to start therapeutic in the multiple sclerosis. Everybody knows that they are the window therapeutic. We must be effective in order to change the progression of the multiple sclerosis. So the immunological therapy are most likely to be effective in the inflammatory phases, and there are several targets of therapeutic. And now I am very happy to introduce the Professor Michael Kornberg from Johns Hopkins University School of Medicine. We will speak about multiple sclerosis, current management, and emerging therapy treatment strategy.
Well, thank you very much, Dr. Barraza. It's very nice to meet you. It's very I'm honored to be invited to speak with you all. I very much enjoy speaking to audiences outside the United States. I often get a very different perspective on MS care, and so it's a learning opportunity for me as well. And so what I was planning to do was to provide an overall view of current management in MS, and also to discuss a little bit about some of the emerging treatment strategies that I think are exciting and may kind of enter clinical management over the next 5 to 10 years or so. I'm not certain of the breadth of the background of everyone on the call, and so I tried to choose the things that are important from my perspective. But I'm very glad that we'll have plenty of opportunity at the end for discussion, because I'm sure that there will be some points I don't discuss or things that I don't discuss in detail that would be useful for many of you. And so I'm looking forward to that discussion. The other thing to say is that I would call much of this presentation editorialized, meaning I'll give you my take on some of the evidence behind these treatments and treatment strategies. But certainly other MS specialists might have a somewhat different perspective. So just something to keep in mind. And so with that, I'll get started. A few disclosures that are worth telling you about. So I have received consulting fees from a number of organizations. And I'm also going to discuss some off-label therapies and emerging therapies that have not yet been approved by any government regulatory agencies. So I know I do not have to spend much time introducing multiple sclerosis, but just to set the framework for the discussion. Multiple sclerosis, as you know, is an inflammatory demyelinating disease of the central nervous system. Inflammatory meaning characterized by immune system attack, with a primary target being myelin, but also with associated secondary neuronal and axonal injury and neurodegeneration. And so this schematic is one of my favorite schematics that captures many aspects of the clinical course of MS. This line in the middle represents clinical disability over time. And as you know, most patients with multiple sclerosis will start out in the relapsing remitting phase. That's defined by these discrete episodes of inflammatory attack in the central nervous system. Each of these episodes of inflammation is associated with neurologic disability. As the inflammatory episode fades, there's recovery of function, sometimes all the way back to baseline, sometimes incomplete recovery. And one of the primary ways that individuals with MS develop disability is by incomplete recovery from multiple relapses. Each of these relapses is associated with a lesion or a plaque that we can observe on MRI. in the brain and spinal cord, and if we evaluate the optic nerves. And also, as you know, over time, many patients who start out with relapsing remitting disease will enter what we call secondary progressive MS. That can be associated with superimposed relapses, but is also defined by this insidious progression of disability that occurs without relapse. And also, as you know, about 10% of people will have a progressive course from the beginning of the disease. And there are differing opinions about this, but I'm of the opinion that all of MS is the same disease and just represents different spectrums of clinical presentation. And so it's through a combination of incomplete recovery from relapse and insidious progression that patients will develop disability over time. Traditionally, we have focused on physical disability. This is a representation of the EDSS scale, which is the traditional measure of disability. It's highly focused on walking dysfunction, ambulatory dysfunction, but we now know that there is considerable cognitive dysfunction associated with multiple sclerosis as well. When I setting up a discussion about treatment and management, there's a few points that I like to start off with, and some of them are just terms that I think it's helpful to think about. So one is relapse, which we also call clinical disease activity, which describes disability that is produced by these discrete episodes of inflammation in the brain or the spinal cord. And then there's also radiologic disease activity, which is defined by new lesions forming on MRI. And the reason I think it's important to understand both of these terms is because ultimately, to me, they represent the same process: inflammatory attack that starts in the peripheral immune system and enters the brain. And some lesions create symptoms at the time that they occur, and some don't. And so every relapse or clinical activity should be associated with a new lesion on MRI, but not all new lesions that you can see on MRI are associated with clinical findings that you would call relapse. So clinical and radiologic disease activity are both representative of inflammation. And that's in contrast to progression, which I defined as worsening of disability that occurs in the absence of relapse and the absence of new MRI activities. And this becomes very important when we think about the treatments that are effective for MS and what the unmet needs are that we must develop in the future. So just a little bit more on this point, just to drive home the message. So relapses and progression can and often do coexist. So there's not some hard defining line when someone transitions from relapsing remitting to secondary progressive disease. Patients with progression can still have superimposed relapses. And so this nomenclature of relapsing for progressive is somewhat poor. Progressive patients can still have relapses, and progressive patients without clinical relapses can still have new enhancing lesions form on their MRI. And the reason this is important, as I'll return to later in the talk, is because the current therapies have really been shown to benefit people who are having at risk of relapse or at risk of new lesions on MRI. And as long as someone has that clinical or radiologic disease activity, those are the patients that will benefit from our current therapies. So a somewhat more useful framework to categorize patients with MS is really first and foremost, is their disease active versus inactive? Active disease means people who are experiencing clinical or radiologic disease activity, whereas progression is accrual of disability without relapses or new MRI lesions. And so when I think of a patient and if they'll benefit from therapy, I try to place them within this framework. And so there are three elements of MS treatment. I'm only going to focus on disease-modifying therapies for the sake of time. But generally, my approach to treatment for MS is threefold. So one is how you manage an acute flare-up or an acute relapse. The mainstay of treatment is going to be corticosteroids. And the primary goal of treatment is to hasten recovery of disability that's associated with the relapse. The second element of MS care are our disease-modifying therapies. And these are the therapies that truly change the long-term outcome of someone's disease. All of our current therapies are really designed to prevent inflammatory disease activity, but as I'll demonstrate, they have been shown to alter the course of disease and improve long-term outcome. And finally, I think a very important element of MS treatment is symptomatic management. So what do we do to help patients cope with their existing symptoms in order to limit the impact on their lives and improve their quality of life? And it's very important not to forget about symptomatic management, particularly for patients with progressive disease. In the United States, I'll often see patients with advanced disability and progressive disease, and a neurologist will tell them, well, there's nothing we can do for you. And I hate to hear that, because even for patients for whom we don't have disease-modifying therapy options, there's still much that we can do to improve their quality of life. But in the context of this talk, I'm going to focus on disease-modifying therapies, a treatment approach, and emerging therapies. So currently in the United States, there are more than 20 therapies that are approved for use in multiple sclerosis. All of these are what I call anti-inflammatory therapies. They are best at preventing relapses and new lesion formation. As a general rule, they all target the peripheral immune system, but they've been shown to prevent or delay disability in patients with active disease. And this is really the important point to me, patients with active disease, because there are some therapies that have been approved in progressive MS. So you might be aware that Ocrelizumab was approved for primary progressive MS. Siponimod, which goes by the trade name Mayzent, was approved for active secondary progressive MS, and a number of others have followed. And with all of these treatments, if you separate the patients out between those that had active disease, meaning clinical relapses, new MRI lesions, those are the patients that benefit. Unfortunately, the patients who experience progressive disability without inflammatory activity have by and large failed to show benefit. However, with that caveat, I think it's important to say that our current treatments truly have made a significant impact on the outcome for patients with MS. And we see this very nicely when we look at natural history studies. So this schematic on the top is a representation of what I call the textbook natural history of MS that most of us learned in med school and medical school in our training. And these days, the clinical course of MS for patients who were diagnosed in the past 10 to 15 years is much different than it was in the 20 or more years before that. And so just to be a bit more specific about that, so the textbook natural history of MS, which are the numbers that you still see quoted quite often, are that by the time someone has had disease for 20 years, more than half of those patients will have transitioned to a progressive course. And half of those patients will require a cane to walk over that interval of 15 to 20 years. This is much different than more recent natural history studies that have shown that over that same time period, less than 20% of patients advance to a progressive disease course, and only about 10% are requiring a cane in that period of time. And now, one very relevant question that comes up is, how do we know that the disease-modifying therapies are the reason behind this change? rather than just differences in diagnosis. So MRIs are much more readily available. The definitions of multiple sclerosis have changed over time. And so how do we know that this is a true impact on the disease course? And there's several lines of evidence that tell us that these disease-modifying therapies, or DMTs for short, have a long-term impact on multiple sclerosis. The most convincing of these, in my opinion, are the long-term extension studies of the randomized controlled trials that were initially done with these therapies. And so what I mean by that is that most of the initial trials for the MS disease-modifying therapies were 2-year studies. Initially, patients were randomized to either placebo control or to therapy, and they were treated for 2 years with placebo or drug. And then after that, generally all patients were started on treatment because these were positive studies. And what we see is that when we follow those patients for another 10 years, the patients who were started on drug rather than placebo have less disability after 10 years than those that were treated with placebo. So even that 2-year head start on treatment makes a difference in terms of long-term disability, which is the best quality evidence we have that these make a difference. We also have a lot of large observational studies that have separated patients retrospectively into those that were treated early, so they received treatment early after diagnosis, versus those in which treatment was delayed. And universally, patients who receive treatment early in their disease course have substantially less disability later on. And so I would say that there is overwhelming evidence that disease-modifying therapies have changed the outlook of the disease for many patients with MS. So that's the success story. The other part of the flip side of the coin is understanding what we are not yet good at. And we do not have disease-modifying therapies that slow progression or that promote recovery from relapse, that promote repair and remyelination. And I really want to emphasize that point because I think certainly in the United States, for neurologists that don't specialize in multiple sclerosis, they will often use therapies like the Anti-Cd20 therapies, Natalizumab, for patients who are experiencing progressive disease. And it's important to make the point that the only patients that benefit are the ones that have evidence of active disease, meaning relapses or MRI lesions. We really have nothing to offer patients who are experiencing this insidious progression without inflammatory disease activity. And so with that, I'd like to kind of give a broad overview of current disease-modifying therapies that are approved for multiple sclerosis in different parts of the world. A little bit later, I'll talk about some off-label immunosuppressive therapies, which is very relevant if we're talking about treatment of MS globally. But in terms of what's approved in much of the world, I separate current MS therapies into 3 tiers of efficacy. So on one end of the spectrum are the medications that are the least effective overall at preventing clinical relapse. And so I'm really defining efficacy by their effect on annualized relapse rate. And so in the low efficacy category are the interferons and glatiramer acetate, which were the first drugs on the market. Teriflunomide, which goes under the trade name of Aubagio, I also put into that category. And these roughly lower relapse risk by about 30%. Then there's a category in the middle that are generally oral therapies that have been shown to decrease annualized relapse risk by approximately 50%. These include the fumarates, of which dimethyl fumarate was the first agent on the market, and a number of S1P receptor modulators, of which fingolimide was the first on the market, and there have been several others that have come on since then. And then finally, there are the high efficacy therapies. And I put down here much greater than 70% because in early clinical trials, some of these showed a 70% effect on annualized relapse rate. But in clinical practice, all of those relapses tend to happen very early on in the first 3 months or so of treatment. And so all of these therapies are highly effective. Natalizumab, as well as the anti-Cd20 therapies and Alemtuzumab, they're highly effective to the point that generally when I have patients, particularly on the anti-Cd20s or Natalizumab, who've been on therapy for more than 3 to 6 months, it is extremely unusual for those patients to have new MRI lesions or clinical relapse. So, the next question might be, well, why don't we always use the most efficacious therapies? And the answer is because there can be a trade-off in terms of safety. And so when I think of these therapies, I think of 3 tiers of efficacy and 2-ish tiers of safety. And the reason I say ish is because this is not a hard and fast rule. But as a general rule, the less effective medications are immunomodulatory. They modulate the immune response, but don't necessarily directly suppress the immune system. And the higher efficacy agents are immune suppressive, which comes with greater risk of adverse events, a lot of them being opportunistic infections, but also cancers and a number of other risks. The one medication that in my mind kind of straddles these 2 categories is Natalizumab, because its safety really depends on your JC virus antibody status. If you are JC virus antibody negative, in my mind, this is an extremely safe medication. If you are JC virus antibody positive, it is exactly the opposite. It is extremely unsafe, and the risk of PML becomes simply too high. And so I told you that I would give you some of my opinion. And so this is a highly editorialized view. But within the world of MS therapies, which can really get very overwhelming, for the neurology trainees in the United States, it's very hard to keep up with all of these therapies. I really only routinely use a subset of these therapies based on the clinical profile of patients. And the reason that I don't use certain classes, such as the S1P receptor modulators, is because in my view, there are other medications that have better efficacy with at least a similar safety profile. So for instance, I feel that the anti-CD20s are equally safe as the S1P receptor modulators, but are more effective. And so that kind of narrows down, the list of drugs that I routinely use in my patients. Very important to say that very good MS specialists at other institutions might have a different view on this framework. So then one of the questions that was raised by Dr. Barraza is, how do you choose among disease-modifying therapies when you are meeting a patient for the first time and you've diagnosed them with MS? So probably the most important thing to start off with is that there's no absolute consensus about the right treatment approach. And traditionally, there have been different approaches to treatment. And these can be categorized roughly as an escalation approach and an early aggressive approach. So an escalation approach is defined by starting with the safest therapies first and only escalating a patient to a high efficacy therapy if they have breakthrough disease, if they have a relapse or new MRI lesions. And that's in contrast to early aggressive therapy, in which we start patients off on the highest efficacy therapy very early on. And so with these 2 strategies, an escalation strategy is really focused on safety. An early aggressive strategy is focused on giving a patient the greatest chance of avoiding future relapses and new disability. What I would say is, as a whole, the field of multiple sclerosis is moving more and more towards being early aggressive. And at this point, this is really based on large observational studies. So there have been many large studies that have looked at large cohorts of MS patients and retrospectively looked at who was started on low efficacy agents and who was started on high efficacy agents at diagnosis. And generally, all of these studies have shown that patients who were started on high efficacy agents early on have less disability after 10 plus years. And so because of this, the field as a whole is becoming more aggressive with our therapies. However, I think it's important to say that there have been no randomized clinical trials that have evaluated these two strategies. And the early aggressive strategy does not really take into account long-term safety. And we don't have some of that data, to be frank. We don't know what being on anti-CD20 for 25 years it means from a safety perspective. And so there are some randomized controlled trials active right now around the world that are specifically comparing these two treatment approaches. Two of the big ones are the Deliver MS and Treat MS trials, which are randomizing patients to these two strategies based on their clinical profile and evaluating safety and efficacy. No matter what strategy you take, as a general rule, I think that most MS specialists would agree that disease activity, meaning relapses and new MRI lesions, is not tolerated. And if someone is on a lower efficacy therapy, then that merits escalation of their treatment. And part of monitoring the effectiveness of someone's therapy is not just evaluating for relapse, but also doing at least yearly surveillance through MRI to detect new asymptomatic lesions. Because as long as someone is forming new lesions, they have an inflammatory component of their disease that is incompletely controlled. And of course, we can't forget that, especially with these high efficacy therapies, there are risks. And so whatever the associated safety laboratory monitoring that needs to be conducted should certainly be conducted. So in the absence of having randomized trials that compare these two approaches, the next question is, so for any one individual patient, how do we decide on a treatment? So there are a number of patient factors that I use when I'm considering whether to be aggressive with a patient or not, and what therapy to start with. And one of the kind of some of the framework that I use is I evaluate them for factors that we know are associated with aggressive MS and earlier onset of disability. And so we know patients that have brainstem or spinal cord lesions at baseline are at higher risk of disability in the long term. We know that patients who have had poor recovery from their prior relapses are at higher risk. And I think, it would make sense that in patients we know have had poor recovery from prior attacks, we want to limit future attacks as much as possible. People who have had a high relapse rate within the first 1 to 2 years, being a male, and in the United States, patients that have African ancestry have demonstrated to have more aggressive disease. So if I'm seeing a patient for the first time and they have a number of these factors, then that's someone who I am going to fall on the side of being aggressive early on. And so I use some of these known predictors of aggressive disease to help me choose an appropriate therapy. But then there's also, at least in the United States, a big element of a patient's own attitudes and preference. I view the choice of a treatment as a partnership between the doctor and the patient. And patients can have very different attitudes about their therapy. Some patients are much more scared of their MS than they are of the drugs to treat it. Some patients are terrified of potential risks associated with drugs. By the same token, some patients prefer to take oral medications. Some people prefer infusions. And ultimately, a patient has to be willing to stick with a medication for it to work. And so I take all of those into account when choosing the right medication for a patient. So with that, I was hoping to just give kind of a broad overview of the current therapies and their mechanisms of action, how they work. So there's a number of immunomodulatory therapies that we really don't know exactly what their mechanism of action is. This includes the interferons, which were the first class of approved therapies in the United States in the early 90s, glatiramer acetate, which followed shortly afterwards. And then more recently, dimethyl fumarate, which I would say is an intermediate efficacy drug, also doesn't have a clear mechanism of action. But we know that all of these work by shifting the phenotypes of peripheral immune cells from pro-inflammatory types that are pathogenic in MS to more anti-inflammatory types. I would also include in this immunomodulatory category teriflunomide, which is an inhibitor of a mitochondrial enzyme that's important for DNA synthesis, particularly in lymphocytes. And so it reduces lymphocyte activation and proliferation. It's an immunomodulatory therapy that generally has been shown to this point to be quite safe with a few exceptions. It has the potential to be a teratogen, and so we avoid it. I avoid it in patients of childbearing age, and importantly, this is both women and men. It has a very long half-life, and so those are the things to know about it. But otherwise, it's quite safe. Another big class of therapies are the sphingosine 1-phosphate receptor modulators. Right now, there are 4 different drugs on the U.S. market that fall into this category. So fingolimod was the original, and then the others are more selective S1P receptor modulators. And these all work essentially by trapping lymphocytes in lymph nodes. And so the S1P receptor is involved in lymphocytes leaving the lymph nodes to go to tissues such as the brain to cause clinical attacks. And S1P receptor modulators cause internalization of this receptor and basically don't allow the immune cells to get out of the lymph nodes and attack the brain, which is also why they carry a risk of infection. Natalizumab, it was one of the first kind of scientific successes in MS because it was really discovered, out of a laboratory based on studies of a mouse model of multiple sclerosis. It is a monoclonal antibody against protein alpha-4 beta-1 integrin that's required for T cells to attach to the brain and endothelium and enter the brain. And so it basically works by keeping immune cells out of the brain. Because of that, it's very effective in MS, but that's also the basis of its biggest safety concern, which is progressive multifocal leukoencephalopathy. But fortunately, at this stage, we know what someone's risk is for PML, and it's really a product of the JC virus antibody status, how long you've been treated, and whether you've previously been treated with an immunosuppressant. And so for anyone treated with an immunosuppressant in the past, the risk of PML becomes too high, and generally it's not used. For everyone else, as long as someone remains JC virus antibody negative, their risk of PML is very, very low, 1 in 10,000 or lower. But if you're JC virus antibody positive, your risk elevates precipitously over time, such that by 5 or 6 years, the risk is 1 in 100, which in my mind and most MS neurologists, I would say is unacceptable. And so we are able to stratify who's at risk of PML and who's not. The other class of medications that has entered the market over the last 5+ years are the anti-CD20 therapies, otherwise known as the B-cell depleters. These are biologic therapies that target a protein CD20 that is expressed on B cells throughout much of their development and causes B-cell lysis and is highly effective in reducing relapses in MS. The interesting thing about this strategy is that it does not have an immediate impact on antibody production because plasma cells do not express CD20. So it's some other function of B cells, such as antigen presentation, that seems to mediate this effect. And then we also have what I would call the immune reconstitution therapies that work by the same strategy, which is essentially to ablate the immune system with the idea that you're getting rid of all of the autoreactive immune cells, such that when they repopulate, those autoreactive cells are gone, and people are no longer at risk of relapse. That includes Alemtuzumab, which is an infusion medication, Cladribine, which is an oral medication, and increasingly there's been interest in hematopoietic stem cell transplant, which is currently being evaluated in comparison to other high efficacy therapies as part of the BEAT MS trial. And so the advantage to these therapies is that they are all quite highly effective. They give the possibility of a short-term treatment that produces long-term benefit, perhaps even a cure of the autoimmune response in MS. But because of their mechanism of action, they intentionally cause profound immune system immune cell depletion, and so they come with, they carry the risks of infection and in some cases cancer that you might expect from that approach. And so again, just to return to my own editorialized approach that I take with patients. For those patients who have aggressive MS, I'm typically in this high efficacy category. And a big part of my decision is whether someone is JC virus antibody positive or negative. If they're negative, I will frequently use Natalizumab. If they're positive, then I use the anti-CD20s. I use dimethyl fumarate and not so much the other newer fumarates because in the right patients, they have a good benefit, a good balance of efficacy and safety. And in particularly my older patients who have been stable for quite a while, then those are the patients I'm more likely to use the low efficacy therapies, and I prefer glatiramer acetate and to the interferon betas just because of the side effect profile with the interferons. So many people experience flu-like side effects and cannot tolerate them. I think when talking to a global audience, it's also very important to discuss off-label alternative immunosuppressant therapies because I'm fully aware that many of the treatments I discussed are not available around the world. And so among those, the best evidence is for Rituximab, which is the original anti-CD20 biologic. I think of Rituximab as being equally effective as Ocrelizumab or Ofatumumab or the newer agents. And it is highly effective in MS. And so I think that this is an excellent choice in parts of the world where other therapies are not available. And in fact, I'm happy to use Rituximab in my patients as well. There's less evidence for other agents, but there is some. So azathioprine probably has the most extensive evidence of effect. And it has been shown in randomized trials to be at least as effective as the interferons. And so it is an option where no other treatments are available. There's less evidence for mycophenolate or methotrexate, but there is some, and both of them seem to have some effectiveness in MS. And so these are options in areas where other therapies are not available, but my preference would always be for Rituximab in this scenario. So kind of getting back to what we're good at and what we're not good at. So we are very good at preventing relapses and new lesions. We are not good at promoting repair, so myelin recovery, and we're not good at slowing progression that happens without inflammatory activity. And the reason for this is largely that the mechanisms that drive those parts of the disease are simply different than what they are in relapse. And that includes both immune-mediated mechanisms and mechanisms that are entirely independent of the immune system, both of which contribute to the failure of remyelination and to degeneration of neurons and axons. So just to kind of drill down on some of that physiology, So in relapsing MS, relapses and new lesions, really they start outside the brain, in the peripheral lymph nodes and the spleen, where autoreactive lymphocytes are activated by antigen-presenting cells. Then they enter the bloodstream and they cross the blood-brain barrier into the brain, where they form plaques that are associated with demyelination and neuroaxonal injury. All of our current disease-modifying therapies are really designed in one way or another to prevent this inflammatory attack. They either prevent activation of lymphocytes in the blood and lymph nodes, or they prevent them from getting into the brain. And that's contrasted with what we see immunologically in progressive MS. So in progressive MS, now we really don't see large-scale infiltration of immune cells from outside the brain. Instead, we have this compartmentalized inflammation within the central nervous system, and it's dominated by macrophages and microglia and astrocytes. And we see that at the edge of lesions. So we know that we have the term slowly expanding lesions. And so we know that there are lesions that have a rim of activated macrophages and microglia that slowly expand over time. And we also see macrophage and microglial activation kind of more diffusely throughout the white matter and the gray matter. And so in progressive MS, it's really driven by innate immune activation within the central nervous system. And there are no current therapies that target the innate immune system within the CNS, which I think is a big reason why we really have not been able to tackle progressive disease. Another immunologic aspect of progressive MS that is distinct from relapsing MS is this increase in what we call leptomeningeal inflammation. So we see increasing amounts of immune cell infiltrates, including organized immune follicles in the leptomeninges. That's associated with demyelination and neurodegeneration in the underlying cortex. This increases in progressive MS, and we don't have any treatments that clearly impact this part of the disease. But then there's also immune independent mechanisms, which really just are a result of chronic demyelination. So when axons are demyelinated, they have to maintain their electrochemical gradient over greater areas of the axons, which is a very energy dependent process. And over time, it appears that axons simply cannot keep up with this increasing energy demand. And that leads to degeneration over time. And by the same token, oligodendrocytes, which are the myelin-forming cells, they not only are important for signal transmission along axons, but they also provide nutrients and trophic support that keeps axons healthy over time. And so the longer these axons have gone without accompanying oligodendrocytes, they lose trophic factors and they degenerate. And this combination of distinct immunologic processes and degeneration from demyelination are really the reasons that we have not been successful in these patients. And so one way of kind of looking at this is that early on in the disease, it really is dominated more by peripheral inflammation. And the longer people have had MS, the peripheral inflammation dies down and it becomes more dominated by neurodegenerative processes in the central nervous system. So with that, I'd like to kind of briefly talk about emerging therapies and treatment strategies that are kind of in the near-term pipeline. Starting out with anti-inflammatory therapies. The first that you're likely to hear about, because it is probably going to enter the market, at least in the United States, within the next year or so, is Oobletupsumab, which is what we call a glyco-engineered anti-CD20 monoclonal antibody that really just demonstrates more efficient lysis of B cells, is going to involve a shorter infusion time. It's been tested in phase 3 trials already in relapsing MS with success. I put this here because it's going to be the newest therapy entering the market most likely over the next year. But the truth is that its role is going to be very similar to all the other anti-CD20 therapies, and I do not expect it to have a major impact on MS care. One anti-inflammatory therapy that I that I am more excited about are the Bruton's tyrosine kinase inhibitors, of which there are several that are currently being tested in trials. So Bruton's tyrosine kinase is an enzyme that plays a role in B cell signaling and also myeloid cell signaling. And several of these are CNS penetrant. And the reason that I highlight this is because there's some hope, although it has not been proven, that these BTK inhibitors will be able to impact that macrophage microglia activation that we see in progressive MS. And so there's some hope that they might have a role in progressive MS. There are 3 current drugs that are in development. Phase 2 trials in relapsing MS have been completed for 2 of these, evobrutinib and tolebrutinib. They have shown benefit in reducing relapse risk. But I think the more exciting thing is that there are phase 3 trials underway in not only relapsing, but also non-active progressive MS, which is really one of the biggest unmet needs in multiple sclerosis. And so the big question in my mind is if these BTK inhibitors will impact CNS myeloid cells to slow progression, if they'll have an impact on macrophages and microglia within the brain. There are some therapies that are emerging in order to treat this compartmentalized inflammation and hopefully produce neuroprotection. One of these is Abutolast, which is a phosphodiesterase inhibitor that has many different mechanisms of action. That in one phase 2 trial was shown to slow brain atrophy in patients with progressive MS. So it remains to be seen if that will translate to a slowing of disability progression in these patients. Another one that was presented at recent congresses is Masitinib, which is a tyrosine kinase inhibitor. That again is the hope is that it will target macrophage and microglia within the brain. That was shown in a phase 2b/3 trial to have a positive impact on disability progression in these patients with non-active progressive MS. And so it remains to be seen in larger studies if it will be effective and what the safety profile will be. Unfortunately, there's really very few therapies that are far in the pipeline when it comes to remyelination. And you know, the only one that really is kind of in phase 2 right now is Clemastine, which I view as more of a proof of concept drug because I don't think it ultimately is going to be very plausible, practical in MS. So it's an antihistamine, but more importantly, an anti-muscarinic acetylcholine receptor antagonist that was identified in screens of drugs that promote the differentiation of these myelin-forming precursors, oligodendrocyte precursor cells, into myelinating oligodendrocytes. And there has been a phase 2 study that showed that it was able to speed conduction through the optic nerve in patients who had chronic optic neuropathy. And now there's a phase 2 trial underway in acute optic neuritis to see if it can improve outcome. But this is a big unmet need in multiple sclerosis. And then finally, I want to touch on some strategies that are really designed to improve the risk-benefit profile of agents. And one of the big ones is extended interval dosing of some of these biologic drugs, which has become particularly important during the COVID pandemic when we're trying to maximize safety for these agents. And so this is applied to Natalizumab as well as the anti-CD20s. So with Natalizumab, there's growing interest in extending the dosing intervals from every 4 weeks to every 6 weeks. And this was based on some early observational studies that suggested that there was a significantly lower risk of PML if you extended individuals to every 6-week dosing. And then recently, this was tested in a phase 3 trial called the NOVA trial, which randomized patients to either every 4 weeks or every 6-week dosing. And looked at new or enlarging T2 lesions on MRI. And the bottom line in my mind is that every 6-week dosing was essentially equivalent to every 4-week dosing. There was a small difference in terms of MRI activity with every 6 weeks, but this was really driven by only 2 out of 250 patients that had some confounding factors. So they had stopped Natalizumab and then had disease activation afterwards, but they were included in the in the every 6-week dose. And so this is a strategy that, that I'm increasingly using for patients who have been on natalizumab for a while. And then similarly, there's a question about whether we can extend the interval of dosing for the anti-CD20 therapies. So rituximab, ocrelizumab, we typically dose patients every 6 months. But there has been good data, some of which I'm showing you here, that shows that the effect on B-cell depletion and the effect on relapse activity actually extends for much longer than that interval. So B-cell recovery happens over the course of a full year or more in patients. And even after that B-cell recovery, it seems that the effect on relapse risk is maintained at low levels for an extended period of time. And so there's a great interest right now in whether we can maintain the effectiveness of these therapies while improving their long-term safety. So finally, to end, some of the key takeaways, that I hope come away from this is, number one, early diagnosis and treatment we know improves outcomes. And so this is really a key goal in MS. The earlier we can diagnose someone, the earlier we treat them, the better they were going to do over time. Having said that, the patients who benefit from our current treatments have active inflammatory disease, meaning they have clinical relapses or new MRI lesions. So patients who have progressive disability that is independent of relapse or radiologic activity do not experience clear benefit. And then finally, there are a number of promising emerging therapies that either target the compartmentalized CNS inflammation that we think is associated with progression, that promote myelin repair, or that simply improve the benefit risk profile of our existing treatments. And so with that, I will stop. I think I've gone a little bit longer than I intended, and looking forward to discussion. So I will stop my sharing.
Thank you, Mr. Michael, for this excellent talk and lecture. And we will say it's the first question. How do you treat radiologically isolated syndrome and clinical isolated syndrome?
Yeah, so that's a great question. I will start with radiologically isolated syndrome. So, as you probably know, there's a lot of debate about that. There have been no randomized trials for the most part. And so you will hear a different perspective from different MS specialists. What we know is that over a 5-year period of time, about 30% of patients with radiologically isolated syndrome will develop definite MS. And over 10 years, that's about 50%. There's some data that starting patients on a disease-modifying drug lowers that risk. The way that I currently approach that is, so in my mind, radiologically isolated syndrome is largely just early MS, where you are kind of catching people before they become symptomatic. Having said that, I look at several risk factors that help guide a treatment approach. And so the same way that there are known risk factors for disability in people with MS, there are known risk factors for risk of definite MS in people with RIS. And so what are those? So the big one is whether you have the presence of spinal cord lesions. So spinal cord lesions greatly increase your risk of subsequently being diagnosed with MS. And so in a patient that has a large burden of spinal cord lesions already, I'm more likely to treat them. The other is age, so that we know that younger patients with RIS are at higher risk. We also know that the presence of oligoconal bands in spinal fluid increases the risk of definite MS somewhat. So as a general rule, if someone with RIS is young, if they have spinal cord lesions, I am likely to treat them. In terms of the choice of treatment, for me, I have a hard time starting someone on a therapy that carries with it risk without knowing that they ever will develop clinically definite MS. So I tend to use safer agents, either immunomodulatory therapies like glatiramer acetate or the fumarates. And so that's kind of, where I start with most of my RIS patients that I treat. You will kind of have some differences of opinion there. And in fact, I know that there is a trial right now that is starting that's looking at ocrelizumab in patients with RIS. But to summarize, the patients that have risk factors for clinically definite MS, I generally treat them, but I err on the side of safer therapies. For CIS, so quite honestly, the group of people that qualify as clinically isolated syndrome is getting smaller and smaller because the definition of a lot of people that would have been clinically isolated syndrome 10 years ago are now actually meet criteria for multiple sclerosis. And so it's kind of a rare person that meets that criteria any longer. However, what I'll say is if someone if someone meets criteria for dissemination in space on their MRI, meaning they have more than one lesion and they've had a clinically symptomatic attack, generally their risk of a subsequent attack is quite high, and so I treat those patients absolutely. And then let's see, I can look at some of the questions here as well. So I see there's a question: what would be the treatment strategy for radiologically active disease without clinical relapses? Yeah, very good point. So the way that I view MS is I think that every new lesion forming on the brain is really a reflection of the same process. And whether you are symptomatic from that lesion is simply a matter of where in the nervous system the lesion occurred. Sometimes, lesions occur in areas where there's a great deal of redundancy. Sometimes they happen in more eloquent areas that cause symptoms. That's often going to be spinal cord lesions or brainstem lesions. And so if someone has new radiologic disease activity, I really view that the same as having a clinical relapse, because the next lesion might produce irreversible disability. And so I view them essentially as equivalent. And if someone is on a lower efficacy therapy and they form new lesion, then I escalate them to something more effective. Another question is, how is relapsing remitting, secondary progressive, and primary progressive MS treated? That is a very important question. So, what I kind of hope to drive home is that to me, the treatment should really be about whether you are having relapses or new lesions on MRI. And regardless of the categorization, you might have progressive MS, but if you have superimposed relapses or superimposed lesions on MRI, then the treatment should be the same. So just to kind of dig down on that a bit more, for relapsing remitting patients, they should always be on a disease-modifying therapy. And the choice of therapy is going to kind of depend on some of the factors we discussed. For patients with progressive MS, it depends on the patient. So I will see a lot of patients who have had progressive MS, either primary progressive or secondary progressive, for 10 or 15 years. They have not had a relapse during that time. Their MRIs have been completely stable for 10 years or more. That is someone who we know quite well is not going to benefit from a disease-modifying drug. We don't have any drugs that really impact that process. So those patients, if I have them on anything, I'm going to have them on a safe first-line agent, like glutamate acetate or the interferon or teriflunomide. However, there are some patients with progressive MS that still clearly have active inflammatory disease. They've had superimposed relapses. They're having new lesions on MRI, and I treat them the same as I do any patient with relapsing remitting MS. The next question I see here is, what do you think of the so-called benign multiple sclerosis? So that is a fantastic question. Traditionally, this term benign multiple sclerosis, it really referred to the fact that even in the pre-treatment era, there were about 20% of patients that if you followed them for 20 years or so, they never developed any substantial disability. And we call that benign MS. What I would say is I definitely think that there is a spectrum of disease in MS. Some patients have very aggressive disease, will have severe disability within a couple of years of onset. Some patients will go, the rest of their lives, without any significant disability. And so we do see in that extent, something that falls kind of in the category of benign MS. That's part of the reason why I think it's important to define who we should be starting on high efficacy therapies early on and who we shouldn't, because if we start everyone on aggressive therapies, there's going to be a group of people that otherwise would have done really well, and we're exposing them to a lot of risk from a treatment. Having said that, what I don't like about the definition of benign MS is that it really ignores a lot of disability that isn't so readily apparent. And so patients who physically are doing well with MS oftentimes have a number of other symptoms at a significantly higher rate than the general population. So cognitive dysfunction, fatigue, depression, anxiety. These are things that are much more common in the MS population. And I think if you see MS patients, you certainly are aware of this type of patient that has no discernible physical disability, but actually is quite miserable because of cognitive dysfunction and fatigue. And so certainly that term benign MS has ignored some other elements, that the non-physical elements of disability that are important in MS. And in that sense, I think it has failed the MS community. But I think the spirit of it is not entirely wrong in that there are some patients with MS who actually will do quite well, even without treatment.
Thank you, Professor Michael. We use the cladribine in after 4 years. What do you use after in the patient who has multiple sclerosis when you use the cladribine after 4 years?
Yeah, no, that's a great question. To be perfectly honest, I don't use a lot of cladribine because I think that the anti-CD20 therapies, for instance, had somewhat greater efficacy even in the short term in the randomized trials, and you don't end up facing the same dilemma that you just described. However, the patients on cladribine, there's going to be probably about 40% or so that are going to continue to have relapses after that 4 to 5 year period of time. No one knows exactly what to do with them. The hope is that at the very least you've changed the character of their MS, so maybe you can get away with using a less effective therapy. Those patients I've encountered to this point who have had clinical relapses after cladribine, I tend to be aggressive with them because those are generally patients that had aggressive MS beforehand. I never use natalizumab in those patients because cladribine is an immunosuppressant and the risk of PML is high. So most often I will use an anti-CD20 therapy if someone has an attack after cladribine.
Thank you. And in your practice, in how many percentage of patients of multiple sclerosis you have arrest the treatments? There is some. Is there any criteria that you use when you want to stop treatments?
Yeah. So you are all touching on the key questions in MS, some of which we don't have great answers for. The data for when it is safe to stop MS, so there's no randomized trials so far, There is a randomized trial called DISCO MS that we keep being promised is going to have results soon. But the data that we have has suggested that patients who are over the age of 50 or 55, who have not had a relapse in 5 years, who have not had a new lesion in 5 years, and have been maintained on a low efficacy therapy, that those patients are the ones that are safe to take off of treatment. My concern is that there are patients who will have disease activity into their 50s and 60s, and so as long as I can maintain someone on a safe therapy that does not put them at risk, I prefer to do that. And so, so my preference has been generally to continue therapy, but not to use treatments that carry with them risk. So I do not like to have patients who are in their 60s on an anti-CD20 therapy. However, if I see patients who are entering their 60s who have done very well on glatiramer acetate or an interferon for more than 5 years, and they're getting tired of their treatment, those are the patients that I feel safe stopping therapy, because I think that they've proven that they've entered that kind of immunosenescent stage.
Thank you. There is a question with, is the protocol the same between multiple sclerosis progressive, primary progressive, and secondary progressive?
Yeah. So I would argue that the protocol is the same. So if you look at clinical trials, the only drug that showed effectiveness in primary progressive MS was ocrelizumab. However, my view of the data is that that is simply a product of how the drug company conducted their trial. And if you look at the Oratorio trial, which was primary progressive MS, about a third of those patients, even though they were clinically progressive, they had enhancing lesions on enrollment, so they had active inflammatory disease. And when you do post hoc analysis, those are the patients that benefited from ocrelizumab, and the patients who did not have new lesions or enhancing lesions really did not. And it's very similar in secondary progressive MS. And so the reason that medicines like siponimod were approved for active secondary progressive MS is because they really are only effective when there is inflammatory disease activity. So my treatment protocol is really the same for both primary progressive and secondary progressive MS. I ask myself, has this person been forming new lesions on their MRI? And in the secondary progressive patients, are they still having superimposed clinical attacks? If the answer to either of those questions is yes, then I treat them, and I don't choose a specific therapy based on the fact that they're progressive. But if you ask some other specialists, they will preferentially use anti-CD20 in the primary progressive MS patients, because that's the one therapy that was tested in a clinical trial.
Another question: what figure of lymphopenia do you consider safe in patients with dimethyl fumarate?
Yep, very good question. So I have an absolute hard cutoff at 500. I start to get nervous when people are in the 600 to 650 range, and then it depends a bit on age. So if I have a young patient who has a lymphocyte count of around 650, I might be okay with that. If I see an older patient in their 50s or 60s with that same lymphocyte count, then I'm uncomfortable with it. And the basis for that is, so to date, there have been 9 or 10 patients on dimethyl fumarate who have developed PML. 5 of them had lymphocyte counts below 500 for 2 or more years. And so that's why the 500 count is absolutely definitive. If you're 500 or less, you need to stop the medication. Among the others, they have generally been patients that are older, so over the age of 50. Most of them had lymphocyte counts 700 or less. There was one of them that had a count that was a bit higher. And so, I view 500 as a hard cutoff. When someone is in the 600 to 700 range, then I consider taking them off. But it depends on their age and their other risk factors.
There is another question about after the PML after Natalizumab, what is the therapy used after in this patient?
Yeah, so it's very tricky. So I am not comfortable using any therapy that carries with it significant risk of immunosuppression after PML. For me, so fortunately, I have not been in this scenario often. Fortunately, knock on wood, I've not had one of my own patients develop PML, but I've certainly treated patients who've had PML in the past. If I start someone back on a therapy, it is a safe first-line agent. So the interferons or glutamer acetate. And I would only very cautiously escalate them past that if they had breakthrough disease activity, because PML is so devastating. Once someone has proven that they've had active JC virus antibody replicating in their brain, it is just so destructive. That then I think you have to fall much more on the side of safety. So if I start anything after PML, it's going to be an interferon or glutamer acetate.
Another question from the pregnancy, the woman who will be pregnant, they use the Natalizumab for how many weeks? You can use in your practice the Natalizumab.
Yeah, great question. So in my practice, I continue Natalizumab up until a woman has a positive pregnancy test, and then I stop it. But you will see some differences of opinion there. So you may be aware already of some of the data, which suggests that Natalizumab is probably safe to continue up until the third trimester. It seems like it's safe up until week 20 to 25. When women are treated with Natalizumab in the third trimester, it can be associated with a higher risk of hematologic abnormalities in the baby, particularly low platelet counts. And so you kind of have to weigh the risk of exposure with the risk of MS rebound. So I continue Natalizumab until conception. I know that there are people that will continue it up until the end of the second trimester. But in my own practice, I tend to be more conservative. And so I stop it once a woman has a positive pregnancy test.
Thank you. There is another question.
I see one question here that says, I have a patient with Raynaud's phenomenon associated with MS. Has it been described in association with multiple sclerosis? To my knowledge, there is a somewhat higher a rate of Raynaud's phenomenon in people with MS. It's not thought to be directly associated with the disease. It's more a reflection of the fact that patients with one autoimmune disease are at greater risk for others. And because Raynaud's is generally kind of a marker of autoimmunity, we do see it with somewhat greater frequency in MS than in the general population.
In some cases, we have multiple sclerosis associated to autoimmune hepatitis. What is the drug that you prefer in this situation?
I'm sorry, can you say one more time? MS in the context
I think you have some case, we have multiple sclerosis associated to the hepatitis autoimmune.
Autoimmune hepatic disease.
Yes.
Yeah. So I don't know that I have a specific recommendation for you in that specific instance. What I will say is that as a general rule, because there are certainly cases of where someone has multiple sclerosis and another autoimmune disease. And what I try to do is find medications that have evidence in both. And so, very commonly, what's more common in my practice will be coexistent multiple sclerosis and rheumatoid arthritis, for instance. And for a lot of autoimmune diseases, the anti-CD20 therapies are very attractive for them because they've been shown to have effectiveness in both of those scenarios. If I have a patient with multiple sclerosis and psoriasis, I might be more likely to use one of the fumarates. There's some cases where someone has an autoimmune disease that really requires treatment with mycophenolate or azathioprine. And in those cases, I usually just start with mycophenolate or azathioprine and then just monitor their MS. Because, as I mentioned, there is some evidence that those other immunosuppressives are also effective in MS. And so, rather than subject someone to multiple agents, I will start them on something that has effectiveness in both conditions and then monitor them closely. And, the only other thought that I'll give is that it's important to avoid medications, that can exacerbate another condition. So for instance, the interferons have been associated with worsening of systemic rheumatologic disease like lupus and rheumatoid arthritis. If a patient has rheumatoid arthritis and MS, obviously you would not want to treat them with a TNF alpha inhibitor, which has been shown to exacerbate MS. So, I usually will, in the case of autoimmune hepatitis, I would probably, just confer with her gastroenterology doctors in terms of what treatments they would typically consider and try to find something that has potential benefit in both conditions.
Another question about multiple sclerosis, pediatric multiple sclerosis. What do you think about the use of off-label of anti-CD20?
So I use anti-CD20 quite often in pediatric MS. Obviously, it's off-label, but it's highly effective. And the dosing is actually a little bit easier than considering the dosing, for some of the other agents. And so I use anti-CD20s in pediatric patients quite a bit, particularly if they have aggressive disease, and particularly if they're post-puberty. Patients who are 14 or older, I very commonly use it in pediatric MS.
Is there here a question about the use of Methylprednisolone during pregnancy, and we ask about the dose and the frequency of Methylprednisolone.
Yeah. So in my practice, and at Johns Hopkins, when we confer with the obstetricians and the maternal fetal medicine specialists, methylprednisolone is generally acceptable during pregnancy. Reserved. So as a general rule, we reserve methylprednisolone in pregnancy for women who are having a relapse that causes significant disability. If a pregnant woman is having a mild relapse, just causing sensory dysfunction that's not really limiting her functionally, will oftentimes avoid methylprednisolone. But it is safe. Other than kind of hastening the lung development of surfactant, it appears to be safe. And our regimen is really the same for anyone else. So generally, we will give 3 to 5 days of 1,000 milligrams IV methylprednisolone daily for 3 to 5 days in the context of a relapse during pregnancy.
And we will use the fingolimod, when you have the lymphopenia under you do in this situation.
With lymphopenia from fingolimod?
Yes.
So, I have a hard cutoff of 200 as a lymphocyte count for people on fingolimod. If they're less than 200, I will typically recheck. If they are still less than 200, then I change therapies. Because in my mind, there are other therapies that are equally or more effective with a similar safety profile. And so generally what I'll do is I will recheck 1 month later. If their lymphocyte count is still less than 200, I will oftentimes have them switch to every other day dosing and then recheck lymphocyte counts every month. And once their count rises to 300 or more, I'll transition them to another therapy. That's my general approach.
Okay. Another question about the treatment of relapse in patients with COVID.
Yeah, so I think the question might be if someone has COVID and then they also experience relapse at the same time. That's tricky. I've been very lucky. I've not yet had someone who is having a relapse in the midst of COVID. I would, unless they were having a very, very severe relapse with significant loss of function, I would avoid high dose steroids. So it's a little bit mixed, right? Because dexamethasone is a treatment for COVID in hospitalized patients, but by the same token, we know that patients who received high dose steroids 1 month before COVID infection actually have a higher risk of being hospitalized or dying from COVID. So in that instance, if someone had a mild relapse, I would defer steroid treatment with the understanding that steroids speed recovery, but they don't necessarily change the long-term outcome after a relapse. I'm also noticing, I think I missed one question from above that says, are OCB or oligoconal bands a risk factor, or is it essential for diagnosis? So oligoconal bands are not essential for the diagnosis of MS. They're actually not well, I shouldn't say that. So, they're part of the criteria for the 2017 McDonald criteria, but they're not essential. What I would say is I actually don't pay much attention to them if someone otherwise has a typical presentation for MS. And something that's important to understand, I think, is the data that we cite when we say 90% of people with MS have oligoconal bands. That was really all obtained from a largely European Caucasian population. When we've done studies in other populations around the world, it seems that those populations may have a lower rate of positive oligoconal bands. So it's certainly not essential for the diagnosis. I find it most useful for people who are somewhat unclear. They've had neurologic symptoms that are not really, they're atypical for an MS relapse, but they could be. They have MRI lesions that are not entirely pathognomonic for MS. In those instances, I think oligoconal bands is very helpful because if they're positive, then that has much greater positive predictive value for MS. I see one more question just came up. When should we stop infusion of Partuximab in patients with MS? So tough question. What I would say is that, I worry about Rituximab as people enter their 60s and beyond. That's when the risks of opportunistic infection go up. That's when the risk of hypogammaglobulinemia goes up. For young patients who are otherwise healthy, at this point, I don't think that there is a clear, stop date. We have data in patients with rheumatoid arthritis that were maintained on rituximab for 20 years and generally did very well. So for young patients who are healthy, I don't have a timeline in mind. I worry about the patients who are in their 60s or beyond. Patients who have remained stable on rituximab and now they're 60, 65, I talk to those patients about de-escalating their treatment.
Thank you for Professor Michael. Mr. Shahidi? Mr. Shahidi?
Yes, I'm here.
I'm here.
So thank you so much.
So I thought to say thanks to Professor Michael Kornberg. It
Yes.
is I'm very happy to be in this webinar, and it's a good talk, and everybody have appreciated this presentation. I think I will to see you as soon in Morocco, Mr. Shahidi.
You will be the best welcome.
Yes.
Yes.
We'll concretize the project sooner.
Yes. Anytime. Yeah. No, thank you very much for the invitation. I very much enjoyed meeting you all and speaking with you. So thank
you for accepting to join us, and hoping to see you, dear colleague, dear friend, for the upcoming webinar on MS and MS rehabilitation on July 15 with Professor Ahmed Borza, who will moderate the session, and Professor Alexios Honoric Sandoval. So he's the medical director, MS multiple sclerosis rehabilitation program at Johns Hopkins Medical Institute MS Center, Baltimore, Maryland, USA. Thank you so much. Have a wonderful and great day.
Thank you very much.
Bye-bye.
Bye.
Thank you.